When addressing respiratory health, understanding the key drugs in treating respiratory conditions is essential. These medications play a crucial role in managing a wide range of issues, from asthma and chronic obstructive pulmonary diseases to infections and allergic reactions. Respiratory drugs aim to relieve symptoms, improve breathing, and reduce inflammation, helping patients maintain a better lung function and quality of life. In this presentation, we will explore different classes of respiratory drugs, their mechanism of action, and how they address specific respiratory challenges. The respiratory system is essential for sustaining life as it continuously facilitates the process of respiration. Through a series of highly specialized organs and tissues, it enables the exchange of gases, oxygen, and carbon dioxide between the environment and the bloodstream. Oxygen, which is vital for cellular respiration, is inhaled through the upper respiratory tract, passes through various passageways, and reaches the lungs. Within the lungs, oxygen moves into tiny air sacs called alveoli, where it diffuses into the bloodstream and binds to the hemoglobin in the red blood cells. At the same time, carbon dioxide, a waste product generated by cellular metabolism, diffuses from the blood into the alveoli and is exhaled. This continuous exchange of gases not only provides cells with the oxygen needed to generate energy, but also prevents the buildup of carbon dioxide, which could lead to acidosis if not properly regulated. Beyond gas exchange, the respiratory system contributes to other vital functions. It is integral to voice production as air passing through the vocal cords in the larynx enables speech. The system also supports the sense of smell, as air conditioning odor molecules flow through the nasal cavity, where the receptors send signals to the brain to identify different scents. Additionally, the respiratory system helps regulate the body's acid-base balance, as the rate and depth of breathing influence the level of carbon dioxide in the blood. An imbalance in this process could alter blood pH and disrupt normal physiological functions, highlighting how critical the respiratory system is to overall homeostasis. Divided into the upper and lower respiratory tracts, each part of this system works in tandem to support these essential functions and maintain the body's internal stability. The upper respiratory tract includes all the structures that air passes through before reaching the lungs. First, we have the nose and nasal cavity. Air enters through the nose, but is filtered by hair and mucus, warmed and humidified. The nasal cavity also houses the olfactory receptors for the sense of smell. Next, we have the pharynx or the throat. It is a muscular tube that serves as a passageway for both air and food. It is divided into three sections: the nasopharynx, oropharynx, and laryngopharynx. Next is the larynx. Located below the pharynx, it contains the vocal cords and is involved in sound production. The larynx also acts as a gatekeeper, directing air into the trachea and preventing food from entering the lower respiratory tract. The lower respiratory tract consists of structures located below the larynx, crucial for the process of breathing. First, we have the trachea or the windpipe. It is a tubular passage reinforced in C-shaped cartilaginous rings to maintain its structure. It conducts air from the larynx through the bronchi. Next is the bronchi. The trachea splits into two main bronchi, the right and the left, each leading to a lung. The bronchi further branch into smaller bronchioles within the lungs. Next are the lungs. These are a pair of spongy organs that house the bronchi, bronchioles, and alveoli. The right lung has three lobes, while the left lung has two lobes, accommodating space for the heart. Next are the bronchioles, smaller passages that branch from the bronchi, ending in alveolar ducts and alveolar sacs. Next is the alveoli, tiny air sacs at the end of the bronchioles where gas exchange occurs. Each lung contains millions of alveoli, providing a large surface area for oxygen and carbon dioxide exchange. Oxygen diffuses across the alveolar membrane into the blood, while the carbon dioxide diffuses out to be exhaled. Next is the diaphragm. It is a large, dome-shaped muscle at the bottom of the thoracic cavity. It contracts and flattens during inhalation, creating a vacuum that pulls air into the lungs and relaxes during exhalation, pushing air out. The respiratory tract's physiology includes three main processes: ventilation, gas exchange, and pH regulation, each of which is essential to maintaining life and bodily function. First is ventilation, or the movement of air in and out of the lungs. It is a mechanical process driven by the diaphragm and intercostal muscles. During inhalation, the diaphragm contracts and flattens, creating a negative pressure in the thoracic cavity that draws air into the lungs. This process fills the lungs with oxygen-rich air, and on the exhalation, the diaphragm and intercostal muscle relax, allowing the elastic recall of the lungs to expel carbon dioxide-laden air. This rhythmic cycle of inhalation and exhalation ensures a steady flow of oxygen into the body and removal of carbon dioxide, making it critical for sustaining the body's metabolic needs. Gas exchange occurs in the alveoli, tiny air sacs at the end of the respiratory tract where oxygen and carbon dioxide are exchanged between the air and the blood. Oxygen from the inhale diffuses across the thin walls of the alveoli into the surrounding capillaries, where it binds the hemoglobin molecules in the red blood cells, allowing it to be transported through the body. Simultaneously, carbon dioxide, a metabolic waste product, diffuses from the blood into the alveoli to be expelled during exhalation. This exchange not only supplies oxygen to the body, but also plays a role in regulating pH in the blood. Carbon dioxide, when dissolved in blood, forms carbonic acid, contributing to acidity. By controlling the rate of the carbon dioxide inhalation and exhalation, the respiratory system helps maintain the blood's acid-base balance, preventing acidosis and ensuring physiological process remains stable.
Inhaled steroids, or also known as corticosteroids, are commonly used in the management of respiratory conditions like asthma and chronic obstructive pulmonary disease. Asthma, inhaled corticosteroids are the first-line treatment for controlling chronic asthma. They reduces the frequency and severity of asthma attacks by decreasing airway inflammation. For chronic obstructive pulmonary disease, in patients with moderate to severe COPD, inhaled steroids are often used to reduce inflammation and help prevent exacerbations. And as for allergic rhinitis, in some cases, inhaled corticosteroids may also be used in nasal sprays to manage symptoms of allergic rhinitis. So, for the inhaled steroids mechanism of action, anti-inflammatory effect, they suppress the release of pro-inflammatory mediators like cytokines, prostaglandins, and leukotrienes, which are substances in the immune system that contribute to the inflammation process. Next is reduction of airway swelling. By inhibiting the immune response, they help reduce the swelling and narrowing of airways. Next is decreased mucus production. They also reduce mucus secretion, which helps improve airflow. Improve response to bronchodilators. Inhaled steroids enhance the effectiveness of bronchodilators, which are medications that relax the airway muscles. When inhaled, the steroid particles travel through the airways and settle in the respiratory tract. The deposition depends on the particle size, inhalation technique, and the patient's lung function. Next is absorption in the lungs. Once deposited in the lower respiratory tract, a portion of the inhaled steroid is absorbed directly to the bloodstream from the lung tissue. The localized effect in the lungs is primarily responsible for the anti-inflammatory benefits of inhaled corticosteroids. For the mucociliary and macrophage clearance, the respiratory system has mechanisms like mucociliary clearance, the movement of mucus and trapped particles out of the airways, and alveolar macrophages, immune cells that remove debris. To clear the particles, including a portion of the steroid, some of the inhaled steroid that doesn't reach the lower airways is either cleared from the lungs via mucociliary action or engulfed by macrophages, reducing its systemic availability. Swallowing and absorption. From the gut, a significant portion of the inhaled dose, especially the large particles that deposit in the mouth or throat, is swallowed rather than reaching the lungs. This swallowed fraction is absorbed through the gastrointestinal tract or GI tract, contributing the systemic exposure. Next is the first pass inactivation in the liver. After absorption from the gut, steroid passes through the liver where a process called first pass metabolism significantly inactivates it. This metabolism reduces the amount of active drug entering the systemic circulation, thus lowering systemic side effects. However, different inhaled steroids vary in how effectively they undergo first pass inactivation. Some, like fluticasone, are highly metabolized, leading to fewer systemic effects, while others are less metabolized and may have a higher risk of systemic side effects. Systemic side effects. Despite first-pass metabolism, some fraction of the inhaled steroid can still enter the systemic circulation, either from the lung absorption or gut absorption. Systemic side effects from inhaled steroids, like route suppression in children, are more likely with long-term high-dose use or in drugs with less efficient first-pass metabolism. Inhaled steroids are commonly used for respiratory conditions like asthma and chronic obstructive pulmonary disease. Today, I'll be covering the three examples of inhaled steroids that we have, which are budesonide, ciclesonide, and beclomethasone. Budesonide therapeutic actions and indications. Budesonide is primarily used for the treatment and maintenance of mild to moderate Crohn's disease. It is also prescribed as an prophylactic therapy in asthma and reduced COPD exacerbations. And its pharmacokinetics is budesonide is a glucocorticoid that reduces inflammation in the respiratory and digestive systems. Its dosing varies significantly based on individual patient needs. And patients should be counseled about the risks like hypercortisolism and adrenal suppression. Contradictions and cautions. It is contradicted for patients with history of hypersensitivity to budesonide or its ingredients, and the inhaled powder form should be avoided in those with severe milk protein allergies. For the adverse effects, common adverse effects include oral infections, nasopharyngitis, and risk of tuberculosis with long-term use. Other effects may involve throat irritation, headache, and respiratory tract infections. For its interactions, budesonide can interact with medications like aspirin, which may increase gastrointestinal side effects, and furosemide, which can result in symptoms like muscle cramps and dizziness. Next, we have ciclesonide. So, for therapeutic actions and indications, ciclesonide treats nasal symptoms linked to seasonal and perennial allergic rhinitis in adults and adolescents age 12 and older. Its pharmacokinetics with high pulmonary deposition and rapid clearance. Ciclesonide has a lower potential for adrenal suppression, making it a safer choice for a long-term use. Contraindications and cautions. Caution is advised as it may increase the risk of infections in the mouth or throat and reduce adrenal gland activity. Its adverse effects, some include an unpleasant taste, dry mouth, hoarseness, mild itching, and joint pain. Potential interactions exist with drugs like Symbicort and alcohol, which could exacerbate side effects. Next is beclomethasone, therapeutic actions and indications. It is an inhaled steroid used for the maintenance treatment of asthma in patients age 5 and older. Pharmacokinetics, it works by suppressing inflammatory cells like mast cells, lymphocytes, and macrophages, which helps control asthma symptoms. Contraindications and cautions. Beclomethasone is contraindicated in patients with hypersensitivity to corticosteroids. Its adverse effects are headaches, sneezing, nasal irritation, and an unpleasant taste are some common side effects. Nursing considerations for inhaled steroids. For our assessment, it is essential to assess patients for contraindications such as allergies and any systemic infections, perform a physical exam to establish baseline data, and monitor respiratory and vital signs. For diagnosis, common nursing diagnoses include risk for injury related to immunosuppression and acute pain from the local effects of the drug. For implementation, educate patients on the proper technique for inhalation, emphasize the importance of oral care to prevent infections, and monitor for any signs of infection. For our evaluation, monitor and evaluate effectiveness of the drug and patient response. Lung surfactants, substances that play a critical role in maintaining proper lung function. Particularly in newborns, but also in adults with certain lung conditions. They are vital in reducing surface tension in the lungs, allowing for easier expansion during breathing. There are two lung surfactants are typically classified into two, which are natural surfactants and synthetic surfactants. Natural surfactants, these are derived from animal lungs and contain phospholipids and surfactants proteins. Okay, so synthetic surfactants, these are chemically synthesized but lack proteins found in natural surfactants. So natural surfactants like Beractant or Survanta, Poractant, Alpha, or Purosurf, and we have Calfactant or Infasurf. So, synthetic surfactants, these are chemically synthesized but lack protein found in natural surfactants. Examples are luxinactant or surfaxin, calfoseryl palmitate, or exosurf, which is no longer in use. Lung surfactants are primarily used to treat neonatal respiratory syndrome. Premature infants often lack sufficient surfactants, which leads to difficulty in breathing and lungs collapse. Administering surfactants helps their lungs function better. Acute respiratory distress syndrome. In some severe cases in adults, surfactants may be used experimentally to improve lung function. Other respiratory conditions, in some settings, surfactants might be used in lung-related conditions where surfactant deficiency or dysfunction is observed. The primary role of lung surfactant is to reduce surface tension within the alveoli, preventing collapse during exhalation. It lowers surface tension. Surfactants consist mainly of phospholipids or like DPP-C and proteins which coat the alveoli and reduce the surface tension at the air-liquid interface. This action allows the alveoli to remain open and prevents collapse of lung tissue. It also increases lung compliance. Surfactants make the lungs more elastic, improving their ability to expand during inhalation by reducing surface tension. It also facilitates gas exchange. Surfactants enhance oxygen absorption and carbon dioxide release by keeping the alveoli open. It also prevents lung injury. Surfactants help maintain the structure of the alveoli and prevent damage from overexpansion or collapse, reducing the likelihood of inflammation and injury. COVID-19 associated ARDS cycle of surfactant dysfunction and lung injury. In COVID-19 associated ARDS, there is a cascade of events that leads to surfactant deficiency, increased inflammation and severe respiratory dysfunction, viral infections and destruction of type 2 alveolar cells. COVID-19 targets cells in the respiratory tract, including alveolar type 2 cells which produce surfactant. The virus can directly destroy these cells, resulting in a reduction in surfactant production. This causes an increase in alveolar surface tension, making the alveoli prone to collapse. Activation of alveolar macrophages and massive macrophage infiltration. The immune response to SARS-CoV-2 leads to the activation of resident alveolar macrophages. Additionally, the inflammatory response attracts a massive influx of macrophages from the bloodstream to the lungs. Cytokine secretion and cytokine storm. Activated macrophages release pro-inflammatory cytokines in large amounts, creating a cytokine storm. These cytokines cause widespread inflammation, damaging surrounding lung tissues, including type 2 alveolar cells, which further reduces surfactant production and leads to more alveolar collapse. Loss of anti-inflammatory and lung protective effects. The destruction of type 2 cells means a significant loss of surfactant proteins, especially SPA and SPD, which have anti-inflammatory and lung protective functions. Without these proteins, the lungs became more susceptible to additional damage from inflammation and infection, exacerbating respiratory distress. Severe loss of surfactant and alveolar collapse. The cumulative effect of surfactant loss, tissue inflammation, and increased surface tension leads to extensive alveolar collapse, worsening hypoxemia, and increasing the work of breathing. This cycle then contributes to the progressive deterioration of lung function typical in COVID-19 associated with ARDS. In a healthy lung, surfactant produced by alveolar type 2 cells plays a critical role in maintaining lung stability and function. This cycle involves production of surfactant by type 2 alveolar cells. Type 2 alveolar cells produce and secrete lung surfactant, lipoprotein complex mainly made of phospholipids and specific surfactant proteins. Surfactant is then spread across the alveolar surface, creating a thin film that reduces surface tension. Reduction of surface tension. Surfactant minimizes surface tension at the air-liquid interface in the alveoli, preventing alveolar collapse, especially during exhalation. This reduction in surface tension stabilizes the alveoli and allows for efficient lung expansion with each breath, decreasing the work of breathing. Anti-inflammatory and lung protective effects. Surfactant proteins also have anti-inflammatory and immune modulating properties, helping to protect the lungs from infection. These proteins aid in recognizing and clearing pathogens, modulating the activity of alveolar macrophages, and preventing excessive inflammation. Clearance and recycling. Surfactant is continuously recycled. Alveolar macrophages and type 2 cells help clear or recycle degraded surfactant, ensuring a balance in surfactant levels. The three examples of lung surfactants are calfactant, peractant, and poractant. Its therapeutic actions and indications. Lung surfactants replace the missing surfactant in the lungs of newborns with RDS, helping stabilize their breathing. Pharmacokinetics. These surfactants are administered intratracheally, working immediately and reaching their peak within hours. Their half-life and metabolic pathways are less defined but follow the surfactant pathways in the lungs. Its contraindications and cautions. Since these are emergency drugs for newborns, there are generally no contraindications. Its adverse effects. Lung surfactants can lead to serious side effects, including patent ductus arteriosus, pneumothorax, sepsis, and hypotension. Lusinactant or surfactant, therapeutic actions and indications. Lusinactant is used for the prevention of respiratory distress syndrome in premature infants at high risk of RDS. It is administered directly to the lungs, where it acts on the terminal airways and alveolar surfaces to reduce surface tension, aiding in lung expansion. For the pharmacokinetics, due to the nature of the administration, which is intratracheal, no human pharmacokinetic studies have been performed to fully characterize its absorption, distribution, metabolism, or elimination. Contraindications and caution. For intratracheal use only, it should be administered by trained healthcare professionals in a clinical setting. For frequent monitoring of lung and compliance and adjustments in oxygen and ventilatory support may be necessary based on the infant's respiratory status. For the adverse effects, common adverse effects include endotracheal tube or ETT, reflux, pallor, dose interruption, endotracheal tube obstruction, and we have interactions. There is limited information on specific drug interactions with lusinactant. Careful monitoring is recommended if any concurrent medications are used, as interactions could impact the infant's respiratory status. Next, we have iscalfoseril palmitate or exosurf neonatal, therapeutic action and interactions, indications. Calfoseril palmitate is used for the treatment of prevention of respiratory distress syndrome in premature infants, particularly those at high risk due to low birth weight of pulmonary immaturity. It acts by replacing deficient endogenous lung surfactant, reducing surface tension, and preventing alveolar collapse. For the pharmacokinetics, calfoseryl palmitate is an intratracheal suspension and is not absorbed systematically in significant amounts when administered properly. Therefore, its pharmacokinetics profile is not well characterized. For the contraindications and caution, it is only for intratracheal administration and should be given by trained healthcare professionals, particularly in infants with a birth weight between 500 to 700 grams. Due to potential severe complications, benefits versus risks should be carefully evaluated before use. For the adverse effects, while the drug reduces mortality in infants with RDS, it may still lead to severe complications and close monitoring is necessary. For the interactions, other drugs may affect the effectiveness of calfoseryl palmitate or increase the risk of side effects. Always consult with a healthcare provider before administering any medications alongside with this treatment.
So now we have here the bronchodilators or the anti-asthmatics. Bronchodilators and the anti-asthmatics are medications used to relieve bronchospasm and treat asthma by relaxing the airway muscles, making breathing easier. There are type of bronchodilators or anti-asthmatics. First is a short-acting beta agonist. These are fast-acting and provide quick relief during asthma attacks. The example of this is albuterol or the salbutamol and levalbuterol. Long-acting beta agonist. These are used for long-term control and prevention of symptoms, often combined with inhaled corticosteroids. The example is salmeterol and formoterol. Next is the anticholinergics. This blocks the action of acetylcholine, leading to bronchodilators. The example is ipratropium or Atrovent and tiotropium or Spiriva. Next is the methylxanthines. These have a weaker bronchodilator effect and are used to long-term control. The example is thiopilin. Next is leukotriene modifiers. It is a type of anti-asthmatics. These block leukotrienes, reducing inflammation and constriction in asthma. The example is montelukast, Singulair. Bronchodilators and anti-asthmatics is used in asthma. It is used to treat and prevent bronchospasms. In chronic obstructive pulmonary disease or COPD, bronchodilators help relieve symptoms like shortness of breath and improve airflow. Next is exercise-induced bronchoconstriction. Some bronchodilators, especially SABAs, are used before exercise to prevent airway constriction. Now I will be explaining the mechanism of actions of some drugs. First is the beta agonist. These drugs stimulate beta-2 adrenergic receptor in the airway, smooth muscles, leading to relaxation and dilation of the bronchioles. This increases airflow and makes breathing easier. Next is the anticholinergics. It blocks the acetylcholine from binding to muscarinic receptor in the airway, which reduces bronchoconstriction. This results in dilation of the airways and decreased mucus production. Next is the methylxanthines. Bronchodilators are used to treat and prevent bronchospasm or the narrowing of the airways in asthma. SABAs are used for immediate relief during an attack, while LABAs or LABAs are other long-acting agents for long-term asthma control. Next is the leukotriene modifiers. These drugs inhibit the action of leukotrienes, which are inflammatory mediators that cause airway narrowing and mucus production in asthma. By blocking this, leukotriene modifiers reduce inflammation mucus and bronchoconstrictions, improving asthma control. Here in the picture, you will see how the bronchodilators and anti-asthmatics work in our system. So in this page, we will be discussing drugs and their therapeutic actions and indication, pharmacokinetics, contradictions and cautions, and adverse effects. First we have here is albuterol or Ventolin, and it is short-acting drug. Its therapeutic actions and indication is acute asthma attacks, prophylactic or maintenance therapy for asthma and COPD. For its pharmacokinetics, its route is in inhalers or nebulizers. The contraindications and cautions of this drug is heart or renal disease, hyperthyroidism, diabetes mellitus, and pregnancy. Its adverse effect is muscle tremors, restlessness, insomnia, tachycardia, palpitation, and arrhythmias. Next is for the salmeterol ceravent. This one is long-acting. Same with the albuterol. Its therapeutic action indication is acute asthma attacks for short-acting and asthma and COPD for long-acting. It is also taken by inhalers and nebulizers. And contraindications and cautions is heart or renal disease, hyperthyroidism, diabetes mellitus, and pregnancy. And its adverse effects, same as with the albuterol also, muscle tremors, restlessness, insomnia, tachycardia, palpitations, and arrhythmias. Next, in the lower part, this is the anticholinergics. The first drug is ipratropium bromide, or the Antravent, and tiotropium bromide, the Spiriva. Their therapeutic actions indication is COPD, treatment of choice, asthma, and then its route of administration is also in using inhalers or nebulizers, and contradictions and cautions is narrow angle glaucoma, heart disease, hyperthyroidism, hypersensitivity, and allergic reaction. Its adverse effect is muscle tremors, pupil dilation, dry mouth, tachycardia, and restlessness. Next we have here is the methylstatin types of drugs. The first is theophylline or Theodor. Its therapeutic actions or indications is asthma and COPD, and the route of administration is in PO and IV or intravenous. Its contradictions and cautions is seizure disorders, heart, renal, or liver disease. Adverse effect is insomnia, nausea and vomiting, seizures, arrhythmias, gastric pain, and hyperflexia. Its drug interactions is with the beta blockers, phenytoin, beta-adrenergic agonists, antidepressants, and certain antibiotics can lead to synergistic effects and cardiac dysrhythmias. Next we have here is the montelukast or the singular. The therapeutic actions indication of this drug is to bind to and block the leukotriene receptors in the smooth muscle cells of the airways. It treats asthma, prophylaxis, and exercise-induced asthma. For the pharmacokinetics of this drug is that montelukast is a leukotriene receptor antagonist that demonstrates a marked affinity and selectivity to the cysteine leukotriene receptor type 1, in preference to many other crucial airway receptors like the prostanoid cholinergic or the beta-adrenergic receptors. Next is the contraindication and caution of this drug. Patients with a history of hypersensitivity to the drug and its components, and the patients with panicularituria or PKU caution be exercised with phenylalanine containing formulations. The adverse effect of this drug is called symptoms such as cough, sore throat or runny nose, diarrhea, ear infection, fatigue, and flu-like symptoms such as fever, headache, heartburn, itchy skin or rash, lack of appetite, nausea, and stomach pain. For the interactions or the drugs that may have an interaction with this montelukast is phenobarbital, rifampin, carbamazepine, phenytoin, gemcitabine, and lopid can have the opposite effect, increasing level of the montelukast in the body. The nursing considerations for these types of drug is the assessment and monitoring of the patient. First, check the respiratory status, lung sounds, and vitals before and after the administration. Monitor for the side effects like tachycardia or theophylline toxicity. Next is the administration. Give bronchodilators before corticosteroids to maintain absorption. Next is the patient education. Teach proper inhaler use, recognize triggers, and avoid smoking or intake of caffeine. Next is evaluate effectiveness. Assess for improved breathing. Next is emergency preparedness. Ensure that the patient knows how to act during an asthma attack.
So for the mucolytics drugs, what is the mucolytics drug? So mucolytics drugs are medication that help break down the mucus by making it easier to expel from the airway. So we have three drugs. So in first we have acetylcysteine, which is the NUC. So acetylcysteine is a mucolytics agent, an antioxidant that is commonly used to break down and thin mucus in the airways. So next, we have ambroxol. So ambroxol is a mucolytic agent and also expectorant agent. This used to help clear mucus from the respiratory tract, and it is commonly prescribed for respiratory condition that involve production of thick, sticky mucus and such as the bronchitis or the COPD. We also know this as chronic obstructive pulmonary disease. Next is the guaifenesin. So the guaifenesin, we this is known as a expectorant. So this used to help thin and loosen the mucus in the airways, and it make it easier to cough up and clear from the respiratory tract. So it is commonly used, include for the over the counter like cold, cough, and flu medication. In here, we will discuss what is the uses of mucolytics drugs. So first, the patient who have chronic bronchitis. So the chronic bronchitis is a part of COPD. So in here, the chronic bronchitis is a inflammation in the bronchial tubes, leads to excessive mucus production. This causes the airway blockage and breathing difficulty. So the mucolytic drugs are very beneficial because they break down and thin out this mucus. It allows to be expelled more easily, which helps improve airflow and reduce the frequency of infections. So next we have cystic fibrosis. So what is cystic fibrosis? So this is a disorder where thick sticky mucus builds up in the lungs. So it leads to severe respiratory issues. So the mucolytic drugs are very essential for people who have cystic fibrosis. So the patient who have this, if they take mucolytic drugs, it will thin the mucus, it will reduce the risk of blockage, they will improve from their breathing and decrease the risk of recurrent lung infection. So next is the COPD. So the COPD, this includes a disease like chronic bronchitis and emphysema. So in here, where excessive mucus can obstruct the airways. So for COPD patients, mucolytics help by loosening and thinning the mucus. So this reduces the build-up in the lungs and making breathing more manageable. So this can lead to improved lung infection and decrease in symptoms like coughing and shortness of breath. So next for the asthma. So in here, this is not commonly used as primary treatment. So the mucolytics can sometimes be beneficial for asthma patients who experience excess mucus production. So in asthma, the primary treatment focuses on reducing inflammation and bronchodilation. So it's opening airways. So however, in certain cases where mucus builds up, it contributes to airway obstruction. So mucolytics
may be prescribed to thin the mucus. It helps to clear it and improve the airflow. So this is often a supportive measure rather than a first line treatment. So next we have the respiratory infection like the pneumonia, sinusitis. So, in respiratory infection like pneumonia or sinusitis, mucus can become thick and sticky by making it difficult to clear and contributing to blockage. So the mucolytics drugs help by breaking down this mucus by making it less viscous and easier to expel from the respiratory tract. So this can improve the symptoms, reduce discomfort, and help clear the infection faster by allowing the body to better clear the airways. So next is mechanism of action of the mucolytics agent. So first, breaking disulfide bonds. So mucus gets its thick and sticky property from mucin, a protein that contains many disulfide bonds which link mucin molecules together. So the acetylcysteine targets and breaks these disulfide bonds by reducing the cohesion between mucin molecules. So this breakdown significantly decrease the mucus viscosity, making it easier for patient to cough it up and clear their airways. So this action is useful in chronic respiratory conditions where thick mucus can obstruct breathing. So next is increasing ciliary activity. So the ambroxol and brohexine. So cilia are tiny hair-like structures lining the respiratory tract that move rhythmically to push mucus up and out of the airways. So the ambroxol and broxine not only reduce the mucus thickness but also stimulate cilia to move more effectively by enhancing ciliary movement. So these drugs promote the transport of mucus up the airways, especially facilitating its clearance. So this action it thins the mucus and activates cilia. It improves mucus clearance and reduces respiratory congestion. So this condition like bronchitis and chronic obstructive pulmonary disease. So next we have degrading DNA in mucus, so the Dornase alpha. So the Dornase alpha is a specialized enzyme that targets and breaks down this DNA by reducing mucus density and viscosity. So by digesting the DNA, Dornase alpha transform the mucus into a less sticky, more manageable consistency that is easier to clear the lungs from the lungs. So next, we also have altering mucus composition. So the carbocysteine. So the carbocysteine works by modifying the molecular structure of mucus by altering its properties to make it less viscous and sticky. So this change in composition makes the mucus easier to mobilize by helping the body to expel it more effectively. So the carbocysteine is often used in chronic condition where mucus buildup leads to frequent coughing and difficulty breathing. So as it makes the mucus easier to clear and reduce airway obstruction. So next would be the mechanism of action of the ambroxol. So what is ambroxol? It is a cough medication which is successfully used in more than 50 countries for more than 30 years. So ambroxol is considered as a mucolytic and expectorant drug, which means the drug breaks up phlegm during bronchopulmonary disease associated with abnormal mucus secretion and impaired mucus transport. So ambroxol promotes mucus clearance, facilitates expectoration, and eases productive cough. Eventually, the patient breathes freely and deeply. So ambroxol include all forms, the bronchitis, the tracheobronchitis, emphysema, COPD, bronchitis, asthma. So during exacerbation of bronchitis, it should be given with the appropriate antibiotic ambroxol. So ambroxol starts working about 30 minutes after it has been taking the breakdown of mucofibers. So it makes the sputum thinner and less viscous, and therefore more easily removed by coughing. Although sputum volume eventually decreases, its viscosity remains low for as long as the treatment is maintained. So ambroxol exert several activities. So one is secret activity promotes mucus clearance, facility expectoration, and eases productive cough. So second would be anti-inflammatory, antioxidant activity. So next would be the local anesthetic effect through a sodium channel blocking at the level of the cell membrane. So ambroxol stimulates synthesis and release surfactant by type 2 monocytes. A complex mechanism that is not yet fully understood. So 4 is would surfactant act as a anti-glue factor by reducing the adhesion of mucus to the bronchial wall, in improving its transport and providing protection against infection and irritating agents. Additionally, due to an increased number of substances that suppress viral replication and affect bacterial biofilm structures. So next we will discuss the three drugs which we said earlier, the acetylcysteine, ambroxol, and guaifenesin. So we will discuss here first therapeutic action and indication of the acetylcysteine. So the therapeutic action and indication of the acetylcysteine reduce mucus viscosity and as a hepatoprotective agent in paracetamol poisoning. So the next we will discuss the pharmacokinetics. So the pharmacokinetics, it's available. So acetylcysteine is available in oral and inhalation preparation. So with an onset of 1 minute and peaks within 5 to 10 minutes, and with a duration of 2 to 3 hours of inhalation administration. So the richest peak plasma concentration approximately 1 to 3 hours after oral administration. So this excreted via urine. So the contraindication and caution for the acetylcysteine. So the caution should be used in cases of acute bronchospasm, peptic ulcers, and esophageal varices. So because the increased secretion could aggravate the problem. So the adverse effect for the acetylcysteine, for the GI, nausea, vomiting, anorexia. For the CNS, headache, dizziness. For underlying cough, so the most important consideration is in the use of this drug is discovering the cause of underlying cough. So prolonged use of the over-the-counter preparation could result in a masking of important symptoms of a serious underlying disorder. So next is the respiratory, rhinorrhea, bronchospasm. Next is for the skin rash. For for the interaction of acetylcysteine, concomitant use with antitussive may lead to a buildup of secretion due to suppressed cough reflex. Avoid concurrent use may increase the vasodilatory and platelets aggregation inhibiting effects of glyceryl trinitrate. So next we will discuss the ambroxol. So the therapeutic action and indication for the ambroxol, it enhances the production of pulmonary surfactant and stimulates ciliary activity by improving mucociliary clearance and easing cough. So next for the pharmacokinetics, it's available in oral form, rapidly and completely absorbed and metabolized in the liver. Excretion is mainly in urine. So for the contraindication and caution, ambroxol should not be used in patients known to be hypersensitive to ambroxol hydrochloride, so or other components of the formulation. So in cases of rare hereditary condition that that may be incompatible with an excipient of the product, the use of the product is contraindicated. So next we will discuss the adverse effect of the ambroxol. So the hypersensitivity reaction would be the rash, pruritus, urticaria, and anaphylactic shock, angioedema. So for the GI, diarrhea, dyspepsia, nausea, vomiting, abdominal pain, heartburn, bloated feeling, dry mouth or throat, and dysphagia, oral and pharyngeal hypoesthesia. So lastly, for the interaction for mucolytic agent of the ambroxol, the interaction would be increase the concentration of antibiotics like amoxicillin, cefuroxime, erythromycin. So next would be the expectorant agent, which is the guaifenesin mucinex. So the therapeutic action and indication would be enhance the output of respiratory tract fluids by reducing the adhesiveness and surface tension of these fluids, allowing easier movement of the less viscous secretion. So the symptomatic relief of respiratory condition characterized by a dry non-productive cough. So the pharmacokinetics would be available in oral preparation, while absorbed from the GI tract. Time to peak plasma concentration approximately 15 minutes. It will be metabolized in the liver and excreted via urine. So contraindication and caution would be this drug should not be used in patients with a known allergy to the drug to prevent hypersensitivity reaction. So this drug should be used with caution in pregnancy and lactation because of the potential adverse effects on the fetus or the baby. So this drug should not be used with the persistent cough, which could be indicative of an underlying medical problem. So for the adverse effect, in GI we have the nausea, vomiting, anorexia. For CNS, we have headache, dizziness. For underlying cough, the most important consideration is in the use discovering the cause of the underlying cough. So the prolonged use of the over-the-counter preparation could be resolved in the masking of the important symptoms of a serious underlying disorder. So next would be the respiratory, or the in here we it the adverse effect of the respiratory is the rhinorrhea, bronchospasm, and then next for the skin is the rash. Next would be the nursing consideration of the mucolytic and expectorant drug agents. So first, will be assessed for any underlying cause of coughing. So in here will be determine if the mucolytics are appropriate. So next is be the assess for any contraindication. In here will be prevent any adverse effects, and then would be the third is the assess for respiratory status. So by monitoring respiratory status will be assess the drug effectiveness, and then next would be the fourth, assess skin for any rashes. By inspecting skin, any rashes will be indicate any allergic reaction. And then fifth would be prevent GI irritation by advising the patient to have small frequent meals. By advising them by small frequent meals to minimize the gastrointestinal upset. And then we'll do a patient education. So we'll be educate the patient on deep breathing, and coughing. So we will teach them deep breathing and effective coughing techniques to aid the mucus clearance. So lastly, we'll be encourage them to increase their fluid intake. So by encouraging the increased fluid intake, it will help thin the mucus and enhance for drug effectiveness.
An antihistamine is a medication that helps relieve symptoms caused by allergies, such as runny nose, itching, sneezing, and hives. It works by blocking histamine, a chemical released by the immune system during an allergic reaction. Antihistamines are commonly used to treat allergies, high fever, and some cold symptoms, and come in both sedating, first generation like diphenhydramine, and non-sedating, second generation like loratadine forms. While generally safe, antihistamines can cause drowsiness, dry mouth, and dizziness, especially with older sedating types. And for the first drug, it's diphenhydramine. The therapeutic action and medication for this is reducing allergic symptoms and causing sedation used for allergies, insomnia, and motion sickness. And the pharmaceutics for this drug is available in oral and intravenous forms, peaks within 2 to 4 hours. And for the contradiction and caution, this should be used in caution in patients with narrow angle glaucoma and asthma. And for the adverse effect, sedation, drowsiness, anticholinergic effects, dry mouth, and blurred vision. And for the interaction for this drug is it may interact with certain medications. The next one is cetirizine. The therapeutic action and medication for this drug is reducing allergic symptoms with minimal sedations, treats allergic rhinitis and chronic hives. And for the pharmacokinetics, administered only peaks within 1 hour. And for the contraindication and caution, this should be used in caution in patients with severe kidney disease and those with liver problems. And for the adverse effects, sedation, drowsiness, xerostomia, dry mouth. And for the interaction, it may interact with certain medications. And lastly, chlorpheniramine. The therapeutic action and medication for this drug is reducing allergic symptoms with moderate sedation, used for seasonal allergies and cold symptoms. The pharmaceutics for this drug is administered orally and peaks within 2 to 6 hours. And for the contradiction and caution, this should be used in caution in patients with narrow angle glaucoma and urinary retention. And for the adverse effect, sedation, drowsiness, anticholinergic effects, dry mouth, urinary retention. And lastly, for the interaction, it may interact with certain medications. And now let's move on to the nursing considerations for these drugs. For the assessment, before giving the medication, review the patient's prescription history and allergy history, keeping an eye out of any indications of sedation or anticholinergic effects. And for the administration, administer the medication as prescribed, ensuring that the patients understand the potential for drowsiness and the need to avoid other CNS depressants. And lastly, for the education, instruct the patient about the medication's purpose, possible side effects, and the importance of avoiding alcohol and other sedatives during treatment. A decongestant is a type of medication used to relieve nasal congestion caused by colds, allergies, or sinus infections. It works by narrowing blood vessels in the nasal passages, which reduces swelling and makes breathing easier. Common decongestants include pseudoephedrine and phenylephrine, available in pill, liquid, or nasal spray forms. While effective, decongestants can cause side effects like increased heart rate, nervousness, or insomnia, and are generally not recommended for extended use, especially in nasal spray form, due to the risk of rebound congestion. And for the diphenhydramine drug, the therapeutic action and indication is phytoephedrine, and direct and indirect acting symptomatic agent is a stereoisomer of ephedrine with lower pressure activity and fewer CNS effects. It acts directly on adrenergic receptors of the respiratory mucosa, causing vasoconstriction. Pseudoephedrine also directed stimulates adrenergic receptors, resulting in bronchial relaxation, increased heart rate, and contractility. And for the pharmacokinetics, the adult, conventional tab, soft gel cup, oral solution 60 mg 4 to 6 hours, max of 24 mg over 24 hours. And for the child, 4 to 5 years as oral solution 15 mg for 6 to 6 hours, max 60 mg over 24 hours. 6 to 11 years old, soft gel cup or oral solution 30 mg for 4 to 6 hours, max of 120 over 24 hours. Onset. Decongestant 30 minutes, duration 3 to 8 hours. Absorption readily and completely absorbed from the gastrointestinal tract. Food may delay the onset effect. And for the distribution, enters breast milk, small amount. And for the metabolism, metabolized in the liver via and the demethylion into norepinephrine or active metabolite. And for the contradictions and cautions, severe uncontrolled hypertension or severe coronary artery disease and renal impairment or acute or chronic kidney disease. And for the adverse effect, allergic reactions, skin rash, itching, hives, swelling of the face, lips, tongue, or throat. And for the heart palpitations, rapid pounding or irregular heartbeat, increase in blood pressure, anxiety, nervousness, headache, trouble sleeping. And for the interaction, bromocriptine, MAOIs like Carbex, LDEV, Marplan, Nardil, and Parnate. Stimulate medications for attention disorders, weight loss, or to stay awake. Medications for blood pressure. Medication for depression, anxiety, or psychotic disturbance like fluoxetine, sertraline, medications for enlarged prostate, medications for sleep, other medications for cold, cough, or allergy. And for the next one, oxymetazoline. The therapeutic action and indication for this drug is this medication is used for temporary relief or congestion in the nose caused by various conditions including the common cold, sinusitis, high fever, and allergies. It works by narrowing the blood vessels in the nose area, reducing swelling and congestion. And for the pharmacokinetics, adult nasal congestion as 0.05% solution. Spray 1 to 3 doses into each nostril twice daily. And for the contradictions and cautions, increased eye pressure, raised thyroid hormone level, heart disease including angina, increase in blood pressure, advanced anteroclosis conditions, children, from 6-year allergy to the drug. And for the adverse effect, slow, fast, pounding, heartbeat, dizziness, nausea, headache, mental, mood changes, trouble sleeping, shaking or tremors, unusual sweating, or unusual weakness. Temporary burning, stinging, dryness in the nose, runny nose, and sneezing. And for the interaction, certain medications for an enlarged prostate such as alfuzosin, dexazosine, prazosin, and terazosine. Certain medications for blood pressure and heart disease such as ACE inhibitors, beta blockers, calcium channel blockers, dexagen, and diuretics. MAOIs such as isocarboxazid, phenelazine, razilin, salazine, xylene, and tricifromin. And for lastly, nafarelin. And for the nursing considerations for oxymetazoline is the first one is to assess the contradictions. Avoid use in patients with hypertension, cardiac disease, hyperthyroidism, or diabetes mellitus as oxytemelazine as can exacerbate this condition due to vasoconstriction. Avoid in patients with glaucoma since it can increase intraocular pressure. The second one is administration guidelines. Instruct proper use. Overuse can lead to rebound congestion, rhinitis medicamentosa. Limit use to no more than 3 days to avoid this. Educate the patient to tilt their head slightly forward and administer into nostrils without taping the bottle directly upward. The third one is monitor for side effects. And for the local effects, dryness, irritation, or stinging in the nasal mucosa. Second one is systemic effects, especially prolonged use, increased blood pressure, headache, or dizziness due to vasoconstriction. And the fourth one, teach proper timing. Recommend administering oxytazoline in the morning to avoid potential stimulation effects like insomnia. And for the nursing consideration for pseudoephedrine is the first one is the assess for contradictions, hypertension, and cardiovascular disorders. Pseudoephedrine stimulates the adrenergic system, which can increase heart rate and blood pressure used cautiously in patients with these conditions. Hyperthyroidism, diabetes mellitus, and prostatic hypertrophy can worsen these conditions. Contraindicated in patients taking MAO inhibitors due to the risk of severe hypertensive reactions. Second one is the monitor for side effects. CNS stimulation can cause insomnia, restlessness, and anxiety. Advise patients to take early in the day to minimize insomnia. Cardiovascular palpitations, tachycardia, and elevated blood pressure. Monitor vital signs, particularly in patients with pre-existing heart conditions. The third one is drug interaction. Be cautious when co-administering with other sympathomimetic drugs or caffeine, as can exacerbate stimulant effects. Antihypertensive drugs may have reduced effectiveness due to cytopherephrine's vasoconstrictive properties. And for the fourth one, patient education. Instruct patients to avoid excessive use and follow the recommended dosage to prevent overstimulation or potential cardiovascular effects. Warn about the potential of mucus, and cytopherephrin is also a precursor in the illicit manufacture of methamphetamine, making it a regulated substance in some regions.
So for the antitussives are medication used to suppress or reduce coughing, particularly in cases of dry non-productive cough. Its uses, like what I have mentioned, dry non-productive cough. Antitussives are mainly used to suppress dry irritating cough that don't produce mucus, especially when cough is persistent and disrupts sleep. Cough from upper respiratory infection, often used to relieve cough associated with colds or the flu. Cough related to throat irritation can help alleviate cough caused by irritation of throat or airways. For the mechanism of action of antitussive, we have central action, which includes the opioid and the dextromethorphan. Antitussives like codeine, hydrocodone, and dextromethorphan works by acting on the cough center in the brain, specifically in the medulla. They inhibit the neural signs that triggers the cough reflex, reducing the urge to cough. We also have peripheral action, which includes the benzonatate. It works by numbing the receptors in the lungs and airways, which decreases the reflex cough. It reduces the sensitivity of the lungs and throat to irritations, stopping the cough at its source. So, important consideration, opioid-based antitussives such as codeine and hydrocodone can cause drowsiness, dizziness, and constipation. They also carry risks of dependency and should only be used under medical supervision, meaning to say it is addictive. Yeah, it is addictive. Next is the non-opioid antitussives. We have dextromethorphan is generally well tolerated but can cause drowsiness or dizziness at higher doses. Abuse of dextromethorphan, example, robotripping, can result to serious effects or side effects. Next, we have here the drug classification of antitussives, the therapeutic action and indication, pharmacokinetics, contraindications and cautions, adverse effect, and interaction. Next, we will proceed for the nursing consideration. So, for the nursing consideration of antitussive, high dosage can cause hallucination and dissociation. Avoid irritants that stimulates more coughing. Teaching related to possible multiple drugs in on one over-the-counter medication needs to be addressed. For example, acetaminophen. Next is, if symptoms persist for more than 3 to 5 days, seek medical assessment again. And lastly, not safe for children 12 years old and below. So, for the nursing process related to the administration of drugs for respiratory system, the nursing process for administering drug related to respiratory system involves a systematic approach to ensure patient safety and effective treatment. First, the nurse assesses the patient's respiratory status, including the symptoms like cough, wheezing, and shortness of breath, as well as the medical history and current medication. Based on the assessment, the nurse formulates a diagnosis. such as ineffective airway clearance or impaired gas exchange. The nurse then creates a care plan with specific goals such as improving oxygen saturation, or reducing respiratory distress. Implementation includes administering medications like bronchodilators, corticosteroids, or antitussives while monitoring for the side effect. And finally, the nurse evaluates the patient's response to treatment and adjusts the plan as needed, ensuring optimal respiratory function and proper medication use.